Hi class, we're back with the second part of chapter 10 for A&P 1. This is continuation of the muscular system. We just talked about the axillary or axial skeleton. Now we're going to move into the appendicular skeleton. Switch to screen sharing with you, and here we go. Sorry if you could hear my husband's vacuuming upstairs. It's a little bit of a distraction. That's okay. Our appendicular muscles, different from our axial muscles. Our axial muscles are stabilizing our head, neck, and trunk. Our appendicular muscles are stabilizing and supporting our limbs. Our upper limbs are positioned, held in place by the pectoral girdle. They originate on the axial skeleton. So pectoral girdle is basically our shoulders, right, the clavicle area, holding on and bracing our arms in place. I always forget to click. The upper limb is muscles that move the forearm, hand, extrinsic muscles of the hands and fingers, and then the intrinsic muscles of the hands themselves. And by extrinsic and intrinsic, we're basically just referring to where they're positioned. Extrinsic muscles are the kind of big ones that go down into the humerus, radius, and ulna, all through the forearm. Intrinsic are just located just within the hand structure itself. And then we have appendicular muscles on the lower limb. You have muscles that move the thigh and muscles that move the leg. And we'll get into all of these. And then muscles that move the lower limb. So again, extrinsic and intrinsic there. Extrinsic are going up into the tibia and fibula. Intrinsic muscles of the foot are specifically dealing with your feet, toes, ankle. Here are those muscle classifications. And notice how even some of these very large muscles are still considered, even though they look like they're mostly in your core or abdomen or trunk area, they're still considered part of the appendicular skeleton by where they insert. You can pause the video here, go back and answer these three questions. So let's talk about the appendicular muscles that originate on the trunk. These are usually the largest of our appendicular muscles. They in general controlling very large scale movements. They're very large, powerful, and they, as you get further away from the body, the core of the body, those muscles are going to get smaller and have more precise, fine movements. So here you can see some of these very large muscles that are originating on our trunk. The posterior appendicular trunk muscles are originating on the large bones of the limbs and the proximal bones of the limbs. And here you see very large trapezius muscle going out to the scapulae, up to the head, all the way down the vertebral column, again assisting with the pectoral girdle. Some of our other deltoid muscle, again, on the scapula and then down into the humerus, very large compared to like our brachioradialis muscle. You can pause the video here, go back and review. Let's keep moving. Muscles that position the pectoral girdle. These are muscles of the chest and muscles of the back, including pectoralis minor, serratus anterior, trapezius, and levator scapulae. These have typically a smaller range of motion than other appendicular muscles, and they ultimately help increase our upper limb mobility, the ability to move that upper limb. There they are. Muscles that position, continuing with that, you also have your trapezius, or our traps. This is the largest muscle in the whole group. It's innervated by more than one nerve, so specific regions can contract independently, resulting in several different movements of our trapezius. So again, you can imagine what this section contracting would look like. That might look like this, right? Where it's contracting or pulling the head down. Whereas if you're trying to contract this muscle here, that might look like this, right? Where you're actually moving your scapula up and down. So again, video here you can look at on masteringAMP.com. You can pause the video, go back and answer these three questions. Let's talk about muscles that move the arm. These originate typically on the clavicle, scapula, thoracic cage, and vertebral column. Latissimus dorsi and deltoid are very large superficial muscles associated with those arm movements, and then there's smaller muscles as well. You can see them here, anterior and posterior. Lots of scapular muscles in there. You'll get to know and love those a lot in lab. Again, most of these are on your list. You can go back to Mastering A&P and watch this video. There's also muscles that are involved in positioning the arm. They have a line of action. This would be like extension, adduction, flexion, medial rotation, adduction, and lateral rotation. And here you can see kind of how they're arranged around our glenoid cavity or around our shoulder joint. Most of our flexors are going to be on the front, extensors are going to be on the back, adduction is going to be up top with our deltoid as well as our triceps and teres major, again, pulling it in, pulling that arm back in. Anterior for medial rotation, that is our subscapularis. Posterior rotation or lateral rotation are the muscles on the back, like the teres minor muscle. So the rotator cuff, this is a common name for a few little muscles that are associated with rotating the arm or moving the arm in that kind of rotating pathway. It's often injured in sports like football, baseball, and SITS, S-I-T-S, is the mnemonic device that you can use to remember it. This is the supraspinatus and infraspinatus, teres minor, and subscapularis. Did I skip? Oh, sorry, didn't mean to do that. It's because I used my little mouse scroller instead of the arrow buttons on my keyboard. Here they are listed for you: origin, insertion, action of all of those major muscles. 99% sure you need to know all of these. You can pause the video here, go back and review. So then we get down into the hand and forearm. They originate typically on the scapula, humerus, radius, or ulna, depending on which part we're looking at. The wrist extensors on the posterior surface, wrist flexors on the anterior surface. So looking at, and I know my arm is not, try to scoot back, not in the anatomical position, but all of these are flexors as I'm decreasing the angle to my body. And back here, these are my extensors, extending or hyperextending my wrist. So extensors on the back, flexors on the front. It's the opposite when we get to the leg. The extensor retinaculum is a wide band of connective tissue holding the tendons of our extensor muscles in place. And then you have a flexor retinaculum that's doing the same thing on the flexor muscles. Here you see them. Pretty sure all of these are on your list. Here's our flexors and extensors. And notice we also have pronators and supinators for that pronating and supinating action. You can go to mastering and watch these videos. This is the chart from your book with origin, insertion, action. You'll notice on the chart that I provided for you, I try to be as brief as possible with the origins, insertions, and actions. They may have several origins, insertions, and actions, and I may have just listed one for you. I tried to pick the simplest one to go with. You are more than welcome to remember a different one than what's on the chart, but I tried to simplify it as best I could for you. Let's talk about some other muscles that move the forearm and hand. Oops, what is going on? Sorry. You have bursa that are surrounding. I swear I'm not touching anything. It's just doing that on its own. That was weird. Okay. Please stop, Mr. Ghost Man. There are synovial tendon sheaths that basically have bursa around them, protecting them from bony surfaces. These tendons of our flexor muscles passing through little tendon sheaths to the deeper flexor retinaculum area. There's also carpal tunnel syndrome. Carpal tunnel syndrome is basically an inflammation of that flexor retinaculum and the tendon sheaths. So it basically is restricting movement, putting pressure on that median nerve that is within that area, and that produces that tingling, numbness, and weakness that's associated with carpal tunnel syndrome. There you see that medial nerve. See a little bit of what I'm referring to. This is right here, this cross section looking at the wrist. You can see some of our carpal bones here and some of our tendon sheaths that are wrapping around some of the tendons on the extensor side of our wrist. Video that you can watch. You can pause the video, go back and answer these 3 questions. We're going to keep moving through and talk about muscles that move the hand and fingers. They originate on the humerus, radius, ulna, and something called the interosseous membrane, which is between the radius and ulna. Usually they're deep to the wrist flexors and extensors, and the deepest digital extensors are associated with movements of the thumb. You can actually see a little bit of movement in my forearm, and you can feel it too when you're flexing or extending your wrist. When you extend your wrist, you can feel them on the back, and when you flex your wrist, you should be able to feel them on the front of your arms. So as with wrist flexors and extensors, again, you usually have extensors on the posterior and or lateral and flexors on the medial and anterior. There you see them. I'm looking through the list. I think most of these you need to know. Here's the chart for you. And here are your extensors and adductors. There's a few in here that you don't need. Again, refer to your list, your chart that I gave you. You can pause the video here, go back and answer these 3 questions. Muscles of the hands typically originate on the carpal and metacarpal bones. These are delicate, fine-tuned movements. More powerful movements are controlled by the tendons that are originating on the forearm. Just makes sense. It's going to be a bigger muscle if it originates from way back here than right here. Extensor tendons tend to dominate that posterior surface of the hand, as I've mentioned. I can pretty much tell you there's maybe only one of these that you need to know. And there's intrinsic muscles of the hands which do not originate on the phalanges. The tendons just kind of extend across the joints of the fingers. Intrinsic hand muscles are responsible for flexion and extension at the metacarpophalangeal joints, adduction and adduction between the fingers, and opposition and reposition of the thumb. You can pause the video here, go back and answer these 3 questions. Now we get into the lower limb. Muscles that move the thigh are typically originating on the pelvis and are associated ligaments and fascia. You have the gluteal group, the lateral rotator group, the adductor group, and the iliopsoas group. So here you see the muscles where they are. These are really good pictures and even better pictures. I really like, I don't know, I like the lower limb muscles. I don't know why. Maybe because I'm a runner. So let's talk about muscle actions. The orientation around the hip basically is going to give you a clue to their actions, kind of like orientation around the glenohumeral cavity. Muscles originating on the surface of the pelvis are going to produce movements that are determined by their position to the acetabulum. So many muscles are very large. They have insertions over a very broad area, so they have more than one action, like the adductor magnus is producing flexion, extension, and adduction. These obviously videos, you can look at masteringAMP.com. Here's your chart. More charts, more questions for review. Moving on to muscles that move the leg. You have flexors of the knee and extensors of the knee, and these are typically opposite of what we saw on our forearm. Flexors of the knee are posterior and medial instead of anterior like we saw on the wrist, and extensors are anterior and lateral. And collectively, we tend to call those the quadriceps muscles or the quadriceps femoris muscles, the extensors. Here we see the back of the leg, anterior leg. Video that's on masteringAMP.com. Another video on masteringAMP.com. Chart from your book. Pretty sure all of these are on your list. Same here. Muscles that move the leg. You have a cross-sectional arrangement where you can see the major position of thigh muscles relative to the femur. The vastus muscles go around the rectus femoris, so lateralis and medialis, you'll see those. It's kind of like how a bun surrounds a hot dog. That's a very weird analogy. Anyways, all 4 of the quadricep muscles are inserting on the patella via the quadriceps tendon. So they all come down and merge together on one tendon and then inserts on the patella. Hence quadriceps 4. Right? You can see them here in this kind of weird view. This is posterior. So here we have our hamstring muscles on the back, semimembranosus, semitendinosus, and biceps femoris. Biceps, you can see the 2 heads here. Medial side, you have our adductors. Lateral side, we have vastus lateralis. This is coming around. If you think of, I just think of soccer players. They always have really, not always, but typically have really good quad muscles and really big lateral quad muscles from all the running and kicking that they do. And that's typically that vastus lateralis that you see on people that have really big thigh muscles. It's on the lateral side. Anterior, you have the rectus femoris. That was that kind of a herringbone like muscle on the front, and then you have your vastus medialis. Sartorius is that muscle that goes right across the front of the thigh, and these are all of our adductors, gracilis, longus, magnus. Here you can pause the video, go back and review. And that little picture description probably didn't do much for you now, but once you learn the muscles, it would probably be good to go back and look at that picture and make sense of it after you've had a chance to look at the models and see what they all are. Extrinsic muscles that move the foot and toes originate on the tibia and fibula, gastrocnemius and soleus being one of them. Those are our largest muscles associated with ankle movement. They produce plantar flexion, and muscles that move the toes, just like muscles that move the hands, are much smaller. Here you see plantaris, gastrocnemius, soleus, popliteus, calcaneal tendon. And then if you go deeper, tibialis posterior, fibularis longus and brevis, flexor digitorum, flexor hallucis. Most of these you need to know for your practical and for the class. All on the chart. Extrinsic muscles that move the foot and toes, you have a large tendon sheath that goes around your tibialis anterior, extensor digitorum longus, and extensor hallucis longus. The sheaths are stabilized by collagen fibers, like your superior extensor retinaculum. That term retinaculum we've seen before when we were talking about the hands and forearms, and then the inferior extensor retinaculum. Some videos here giving you an overview, chart giving you an overview. Another chart, you can pause the video here, go back and answer these 3 questions referring to the ankle and foot. Then you have intrinsic muscles of the foot originating in the tarsal and metatarsal bones. The retinaculi help to stabilize those, and they're more numerous on the inferior surface of the foot, the bottom, right? And they occur in several layers. Hence, we have those arches, which are pretty complex on the bottom of our foot. Charts, and intrinsic muscles of the foot basically provide padding or assist in maintaining those arches, as I was just mentioning. So you can see all of these aponeuroses and tendons on the bottom, helping to keep the muscles up so they can stay in contact with the toes, and lots of fat on there for padding and cushioning as well. Pause the video here, go back and answer these 3 questions. Let's talk about the deep fascia and limb compartments. The deep fascia is basically separating the limb muscles into separate compartments. So within each compartment, the muscles have specific functions, and each compartment has its own blood supply and nerve control. Generally not in communication with other compartments, which is a good thing because when your body especially is trying to do fine movements, you just want one finger to flex and not all of them at the same time. It's also going to prevent infection and pressure from changing from compartment to compartment. The deep fascia is clinically important as well. Trauma to the limb can lead to bleeding, and so the deep fascia is there to innervate, relieve pressure, or increase the pressure depending on what needs to happen in that area. And it's basically there to help isolate that area again, just like our other tissues. Deep fascia can also lead to something called compartment syndrome. This is where you have such an elevated pressure within a compartment or within a compartmentalized area of muscle, maybe because the muscle has grown too fast, maybe the blood supply has increased too much, that it increases the pressure in that area drastically, so that the blood is actually constricted from that area. Blood starvation occurs or ischemia occurs. This can actually lead to paralysis if it's not relieved. Typically, relieving it just involves cutting it open and allowing that pressure to be released. It's typically not a very common thing to happen, but it is known to happen in athletes who overtrain and grow muscles too big too quick, so can be pretty dangerous. There's the different compartments. As you can see, all of the different fascia surrounding the compartments in these different areas. Compartments are a good thing because they provide isolation, but can also be a dangerous thing when we're talking about compartment syndrome. This is the last slide of this chapter. You can go back and answer these 3 questions. Let me know if you have questions about the chapter, if I went too fast, if you think I said something wrong, or if you want clarification. That's what I'm here for. Please let me know, and have a great day.